And get started. Hold on just one moment and I will let everyone in.
Thank you.
Go ahead,
Good afternoon, colleagues. I trust that you're all well. It's really wonderful to have you join our webinar today, where we're talking about issues on disability and the care economy. We are really very pleased to have the panelists here, but more importantly, to have you join us for this conversation. This is the second in the series of conversations focusing specifically on the invisible area, the invisibilizing of issues around disability, care, inequality of care, and how there's discrepancies in the North and the South and the way that disability is attended to. I really want to also thank here our co-partners, Charlotte McLean-Clapo, the team, Leslie Swartz, who sort of got us to kickstart this idea on working on the area of care, of the care economy, and specifically on disability. I'll do a little bit more introducing of Leslie in a moment. We also have colleagues here from the World Bank, and are especially pleased and honored to have Vic McKinney and Mike Smith here, who would be later talking in the fireside chat, moderated by Charlotte. And I think our session today is a fairly informal session. So what we would like is just some housekeeping. Please say whatever you want in whichever way you want to say it. We have the chat function in which it would be really nice if you could introduce yourself, who you're doing, who you are, your organization, what you're doing, what you think about the music of James Brown. And we'll also have some closed captioning and it's available in English. So please go to the bottom of your screen. There's an icon that says CC for closed captioning, which you can click and select subtitles. And you can also use the show full transcript, which will, if you prefer, having the running commentary on the side. This session will be recorded and posted on both the World Bank website and on our website, and we'll send, and it's available for everyone to use. Please feel free in the chat box to link resources, articles that you have that would be valuable for all of us. So having said, where this started from, we're living in the age of the pandemic. We have the new pandemic of COVID. We've had the ongoing pandemic of racism, the pandemic of settler colonialism, and so all of these coalesce together to marginalize really important conversations. Our task today is really to invite everyone to rub the band-aid off some of these silences, claim one's voice, and speak about the issues that are important to us. So having said that, I want to, we'll have 5 presentations, short presentations after each other, and I'll introduce the speakers as they come. So without any further ado, let me welcome and pass over to my colleague, Leslie Swartz, who's a clinical psychologist at the University of Stellenbosch in South Africa. He has been centrally involved in the work in disability and a champion for attending to these issues in a formal way, both through academia, but also within community. He's written just a lovely book, which I will encourage you to buy. I don't know if we have a pirate copy on a LibGen, Leslie, but I'm sure it'll come up there sometime. But really, just if you can get that book, I'll post a link to the book on the chat just now, which is available at Amazon. And if you want a signed copy, then you can make some contact with Leslie. Leslie's also been centrally involved in developing the next generation of scholars in South Africa, who would be then picking up the baton and taking it forward in the important conversations that impact both on our continent in Africa, but also will have impact in globally. So Leslie, welcome. I hand over to you.
Well, thank you very much. Thank you, Umesh. It's a real honor to be part of this group and to have this opportunity to talk. It's a great pleasure. And thanks to everyone behind the scenes who's put this together. It's my job to give a very, very quick overview of an introduction to the issues that we're going to be talking about today. And I have a few slides which Anna can be started from your side. Not that one. Can we have my one, please? Yeah, there we are. Okay, great. So my job is to set the stage. So if we can move on to the next slide. And so we're going to be talking today about the care economy. And it's a true but hidden feature of life for all of us that care is central to how we live our lives and how we look after or do not look after one another and our environment. A lot of the care that we see throughout the world is raced and gendered. The burden of care commonly in families falls on women. This is probably universal, and a large amount of care is undertaken by people of color throughout the world. What's often not recognized is that care is a huge international industry, and there are large flows of money associated with care. We're going to hear something more about this in the other presentations. And it's becoming more and more into focus as populations age globally, because care is more obvious. Care is everywhere, but we often don't see it. And part of this is because in the dominant global north, values of independence are often foregrounded, and they tend to obscure the fact that everybody, no matter how powerful and however independent they look, is dependent on a whole lot of other people for things to happen. So I'm here talking to you partly through the labor of many people behind the scenes, although I may look like a very independent person. It's difficult to cost care. I mean, this is one of the jobs that we do need to do because it's everywhere. It's often informal, and it's often not even thought about. And my particular interest in care comes from my interest in disability. So one of the world's largest minorities of people with disabilities, and according to the World Bank WHO figures, it's roughly 15% of the world's population. Can we move to the next slide, please? So care is linked also to features of a changing world. And as part of what has been termed the care crisis, with these changing demographics, there's been this huge growth in the care sector. But this growth links to migration of health workers globally. So who is actually doing the caring in wealthier countries and communities? And it's often poorly paid, quite vulnerable workers, often working off book and so on. And there are issues of race, gender, and class as to who actually does the care work. And in the economies of low and middle income countries, formal and informal remittances from care workers in the global north play a hidden, often hidden, but very important role. So even in wealthy countries where disability is a key right and equity issue, there is a link with equity and access in less wealthy countries. And the link is often, in fact, through the global transactions of care. We discussed this in more detail in our previous webinar, and I've put the link there from you. As we go to the next slide, the COVID-19 pandemic has really brought issues of care into focus. And as with all other issues, I mean, I'm certainly not the first person to mention that COVID-19 has highlighted and exposed existing social issues and inequalities. With lockdowns and the pandemic, we have seen decreased access to healthcare for vulnerable people, issues of transport. All of these issues have been there before, but they've become more obvious, I suppose, in the context of the pandemic. There have been issues of accessibility to materials that we need in order to survive, even issues like access to masks and masks that are easy to put on. There have been interruptions in life-sustaining care, questions about who actually gets care and on what basis, and this has been shown to be a matter of life or death. There's some British data which is very strong on that. And one of the issues that I think is going to be very important for the future is the whole question of long COVID and what long COVID is going to do for participation, health, and the ongoing need for care. I have noted some of the work that Vic McKinney, who will be talking later, and our other group who are working on COVID issues and disability in South Africa, some of the materials that we've written. And I don't have time to talk about the work that we've been doing, but I just want to give you a flavor of the kinds of issues that are coming up for our research participants. And these are on the next slide. And what I've chosen just to talk about here very briefly is that in the context of COVID, there's been a disruption of service and quite much higher rates of perceived injustice. So some of our participants said, nobody's allowed to accompany me under conditions of lockdown to the hospital. Being disabled or being immunocompromised, you need that support. So COVID has interrupted existing problems with support and care. I do not have a wheelchair. I use the electric one, but it doesn't have a battery. I can't get a battery. So I don't have any transport and I can't go anywhere. And one of the people who we interviewed who has quadriplegia said a quad died in hospital because he couldn't get assistance. The medication was cut off because they couldn't even assist him until he died. The right of life has just been taken away because he's not like anybody else. And there are many, many more examples of how the exclusion of people who are particularly vulnerable and particularly needing of care has been exacerbated and actually shown to be made more visible in the context of the pandemic. As we move on to my last slide, as part of the introduction, and my colleagues will be talking more, I just want to raise what I think is a complex and difficult issue. None of us in this webinar, as you will see, has answers for everyone. We're really trying to raise a series of questions. And I want to note that care relationships are often hidden, and the care itself is often devalued, partly because of its association with female gender, people of color, people from the global south. There are essentialist ideas about culture that naturally some people in certain cultures are more caring than others. Naturally, women do caring and men do not. These are essentialist ideas which are helping to reflect but also reproduce existing inequalities, which I think relate to fears that every single human being has. We're all afraid of our frailty. We're all afraid of our vulnerability. And we need to think about this. Many of the care relationships in the world today are unequal, they're exploitative, and they're hidden. But there is also, and we need to recognize this, genuine intimacy in the context of these relationships. So one of the things we need to get our minds around is how in the battle for the rights and the recognition of people who do care work, do we not lose that intimacy, that reciprocity, and so on? How do we recognize care, create a more equal society in a way which is not exploitative, but which also values care and rewards care as part of the humanity of us all? And we'll hear in the subsequent talks today much more about these issues, and I hope that we have some discussion about this. Thank you very much. I'm going to hand over to the chair. Thank you.
Leslie, thank you very much for that. And also, it must have been so hard to stick to 10 minutes. So we really, really appreciate that. I think we will have a chance later in our Q&A to unpack some of the issues that you have flagged very nicely here, and especially around specifically around issues around inequity in the global north, the global south, and especially inequity across the disability in the care economy. The impact of these and have been felt very, very severely in the COVID period. And it's a good segue for me to introduce our colleague, Bonga Chiliza. And Bonga Chiliza is Associate Professor and Head of Department of Psychiatry at the University of KwaZulu-Natal, who will speak to us a little about the links between the care economy and mental health. And Prof. Chiliza is also the president of the South African Association of Psychiatrists. Bonga, I hand over to you.
Sure, thank you so much, Umesh, and good afternoon, colleagues. I'm really pleased that I'm part of this panel and looking forward to learning and sharing some of our experiences. I've got a few slides, if we may start to show them, just to talk a little bit about mental health and the care economy. So can I have the next slide, please? So I think in South Africa, which we really have lived through one of the biggest tragedies when it comes to mental health care in our country, which I think will become a bookmark for most people that are presenting. I'm going to share a link afterwards just of the story of this life healthcare Esidimeni. But just briefly, the Gauteng government, which is one of the provinces in South Africa, decided to close down the Life Healthcare Hospital, which was a large hospital, I think, with about 1,400 people with severe mental illness and intellectual disability. They shut that down. They hastily transferred patients out into unlicensed NGOs, and within a few months, we started hearing reports that a lot of those mental health care users were dying. And so an investigation happened, and I think was real tragedy to hear that about 140 of those mental health care users subsequently passed away in unlicensed NGOs. And there's been a number of different legal sort of things to try and work out who was at fault for doing these things. And at the moment, there's an inquest that is happening for the judge to try and see who will take if there will be criminal prosecutions that need to happen. But prior to that, there was an arbitration of sorts between the families and the government, because the government was scared that those families are going to sue the government. And so the retired Deputy Chief Justice actually made some scathing findings against the government and awarded the claimants a substantial amount of money for different things. Next slide, please. I think what this is kind of the lessons learned for the Global South, perhaps, are really came out following this. There was an investigation by the South African Human Rights Commission that told, I think, those of us who work in the mental health care what we already know, but that there's really, because of stigma, because of poor investment in mental health care, that we really have serious systemic neglect of our mental health care in our country, in South Africa. We clearly spend a huge amount of money in hospitals. So we've got a very hospital-centric care. Majority of the money that we use for mental health care is actually in psychiatric hospitals, where else we really should be deinstitutionalizing the care and providing it to the people. And what this has led to is that a lot of the work that we do is around first episode psychosis, so seeing our people for the first time. There's multiple sort of reports written on how there's delays in the pathways to care. And this has really, I think we know a lot about why that is, and because of different people going to different healers and biomedical practitioners. but the amount of effort and energy and resources that families require to get someone who is a psychotic young man in the rural areas of KwaZulu-Natal, for example, to get them to care is really something that is understudied, and we really need to be spending a lot more time trying to work out exactly what that means. Next slide, please. So in terms of COVID-19, as Leslie has said, it really did put a spotlight on our mental health care. Even the limited little resources that we have in our hospitals, which is very hospice-centric, as I said, there were fights for our beds to use for COVID-19 patients. The treatment pathways for our patients with severe mental illness and COVID were really, until maybe the third wave, became a little bit more clearer. So it was clear that there was neglect of mental health care users. And of course, the issue of what do we do with those limited resources, like, for example, if the high care or ICU and things like that. And so there were some stories initially early on in the pandemic that if you have schizophrenia, for example, you may not be very high on the list of getting an ICU bed. So I think this has really kind of highlighted as I said, some of the shortfalls of our healthcare system. And there's no doubt now that we really need to move away from a biomedical model of care to a much more human rights-based mental health care system. It's clear that we need maybe a social social models to try and think about how we care for people with serious mental illnesses. And that includes spending quite a bit of time enhancing the care from different sectors, sort of having multi-sectoral approaches. As Leslie kind of mentioned, we need to look at access to care. People seriously struggle with things like transport, or have got serious mental illnesses. People struggle with language and how to talk to English-speaking psychiatrists and medical doctors, and how to get community support for the people that are living in those homes. And then lastly, I only had a few minutes, but lastly, I just want to say that it's very clear to us that we now need to work very much hand in glove with people with lived experiences of psychosis. And I'm quite excited that I'm part of the Lancet Psychiatry Commission on psychosis in the global context, which has really tried to get effective participation and inclusion of people living with psychosis. We've got some amazing people on there who are putting us on our toes, all the commissioners, to make sure that they're inclusive in all parts of this report. And I think at the moment, I just want to say that what has come out very loud and clear from them is that there are really no governments in this world, in the global north, or anywhere really, North America, who have got this right, who've got the care of people with serious mental illness right. And therefore, we need to, as global researchers, need to stop this thing of kind of saying, well, the global north has done this thing, so how do we translate this one bit of system to the global south? It's not going to fly because no one has really gotten that care correctly. But we're looking forward to the commission report, which should be out hopefully in May next year. Thank you so much, Mesh. I hope I stuck to my 5 minutes. Thank you.
Thank you very much, Bonga. That's absolutely fine. And if we can always give you a little medication to help you with this in the future. I also want to say the Lancet Global report on which the commission in which you serve, also has had input from you and others around indigenous systems and how these indigenous systems have understanding of psychosis in a different way. So it's a really nice ground up contribution. So thank you for leading on that as well. Thank you very much. I want to welcome Samira Maziad Al-Tuaraji, who is the lead on population and development at the Health, Nutrition and Population Global Practice at the World Bank. Samira, assalamu alaikum and welcome. Over to you.
Thank you very much. Alaikum salam. Thank you, Chair, for the introduction. I think the presentation, excellent presentations by my colleagues, Leslie and Bonge, had actually made my life a tad easier because the context is actually very comprehensive. And I am going to tell you a little bit in the 5 minutes I have about what the World Bank views are and work on the disability and the inequalities that everyone was talking about. As a multilateral and often a financial institution, the social determinants of health are actually quite important for our work. And this stems from gender, poverty, fragility, conflict, violence, and also disability. Next one, please. So we're cognizant at the institution that the care economy can actually be presented as a very powerful entry point for ramping up and encouraging female employment. But also at the same vein that the solutions to actually reducing these gender gaps in the labor markets have many aspects and many corners and many contributors. But we need a well-functioning care economy that actually is important for all the stakeholders and for all the players. And I'll give you an example. Married women, for example, spend between 14 to 42% of their non-leisure time doing childcare, in comparison to 1 to 20% for married men. And changing demographics, aging, which was alluded to in the previous presentations, declining fertility rates also make the burden of the elderly care actually fall squarely on the shoulders of women and girls within the household and also within the communities, and it's a growing challenge. The care economy as it stands today in our world, and I am not an economist, I'm a physician, but at the same time, I deal with all of these things at the same time, has many intrinsic inequalities into it. And I am going to be focusing in the next few minutes on disability and gender, because to me, these are probably the two top ones that are presented to us in our work. Next, please. So again, within the COVID context and the care economy, I think we've all been confronted with many challenges, and it's really business unusual rather than what we used to do. Women jobs are almost twice as vulnerable to this crisis as men's jobs, because women make about 39% of the global employment, but only account for about 54% of the overall job losses. And this is because of the nature of the jobs that these women are doing. Also, the virus has significantly increased the burden of unpaid care, schools closures, people who are losing their jobs, and many other factors that actually led to the care for the family and the communities falling on the shoulders of women again, and it's often unpaid. So this is another inequality that's intrinsic to how the system of the care economy is operating. Disability, of course, impacts on women are also disproportionate representation in the industry and are more affected by COVID-19 than men. And the pandemic can both incite and exacerbate violence against women. And we've seen this across the board, whether it's domestic violence or it's even within the healthcare delivery system. There are also noticeable forms of violence, whether it's deprivation of the essential health services, especially for pregnant women and women who had just had babies, also the family planning issues, but also against the female health workers, especially when it comes to not easy to come by services like the vaccines, for example. And we could talk about this in more elaborate details, except the time wouldn't allow for this. Next one, please. In the same vein, the business unusual when it comes to COVID-19 and the care economy, women, we know that make up the large part of the health workforce. They also have less decision-making capacities, and their agency is usually overshadowed by men because women compromise the lower sectors of the healthcare delivery system. Women are not physicians, they are not hospital directors, they are not government employees at a decision-making level. So the new measures really are needed to safeguard all of these economic opportunities during COVID-19 to ensure that all those wins, especially the legal wins women have made in the workplace for the past 50 years are actually not lost or wiped out. We also know that most primary caregivers to the ill are women, which also further exposes them to the infection. So this is another vulnerability, another area where gender plays a very important role. Women also traditionally in many communities and in many households, whether it's the global south or the global north, also carry the responsibility for caring for children and the elderly. And then they often also remain in that role during the outbreak or the pandemic. And also women provide care, continuous care for the disabled in their households. And women with disabilities themselves actually have to face this double burden, being in need of care themselves and also held responsible for the care for others within their households. Next, please. So what do we do? What is our response? The World Bank actually had stepped up a lot of its support to countries as they tackled this unprecedented threats posed by the COVID-19 crisis, and paying a special attention to the pandemic different impacts on men and women. And we've been very cognizant of this differential from the very beginning. And we were taking measures to actually advise and urge healthcare. And I'm just talking about what we're doing within the healthcare system. And I am very cognizant of the fact that this is a multi-sectoral response. Health alone cannot do it, so are other sectors. So we urge our healthcare leaders to actually consider the linkages between the human capital formulation and inequalities like disabilities. And we've been working on this human capital framework for the last about 3 or 4 years, taking into account that we don't want to have stranded human assets from birth where people have all this potential until this potential is actually realized. We also urge them to adopt an inclusive human-centered design. Data collection is extremely important and it's often missing from our client countries and our counterparts in the countries we are trying to help. So the disability data is very important in order to measure and manage the outcomes. People with disabilities must be included in research studies, in clinical trials, and also in data collection. And we also encourage developing training programs for healthcare professionals that has to be aligned with the specific care needs and the rights of persons with disability. Finally, I wanna close with the social norms that are strongly highlighting the role of women as caregivers. There is actually a huge scope for policy that are aimed at increasing the capacity, quality, and availability for childcare alone and early education as complementary for home-based care for women who actually need childcare support and make them free their time to either be more competitive in the labor market or have much better quality care that they are providing to the people either with disabilities or without disabilities in their hotspots. Thank you so much. I'll leave it there and I look forward to the discussion.
Jazakallah, thank you very much, Samira. You flag the issue of gender and disability very, very beautifully. And I want to then move on to welcoming Emanuela Fozan, who's the Senior Gender Equality and Non-Discrimination Specialist at the International Labour Organization, who has extensive experience in the Middle East and serves now focusing on women, the gay economy, pay equity, and violence and harassment in the world of work. Emanuela, over to you.
Thank you very much, and it's very nice to be part of this panel. So thank you to all the organizers. And I think that I want to start with a positive note because during this past few years, we have seen some more attention to the overall framework of care work. And certainly COVID in a way has also highlighted the key role that paid and unpaid care, as already mentioned by some other colleagues, play in the normal functioning of our societies, but also the complexities of the overall world of care work. The many elements and relationships, including employment relationships that are involved in the care world. and its human and social and economic aspects, and therefore the need for a comprehensive framework for care work, which is what the International Labour Organization looks at. Now, because I have a very short time, I only focused on 3 points for reflection using the disability lens. And the first one relates to the relevance of care policies. So luckily, right now, there is some attention to care policies. It was not there a few years back. So it's good to see that the policymakers are looking into this. And care policies are those policies that allocate resources to recognize, reduce, and redistribute unpaid care work. And this can be in the form of money, in the form of services, but also in the form of time. And so here we are talking, for instance, of care services, care-related social protection transfers and benefits, but also care-related infrastructures and care leave policies and family-friendly working arrangements that are also relevant to people with disabilities. These are policies that have enormous potentials to be transformative when they guarantee the human rights, agency and well-being of both the care taker and the carer. And these transformative care policies can therefore yield very positive health, economic and equality outcomes, leading to better outcomes for all, including for people with disabilities. But only when these care policies are well packaged and well funded, they can actually exert transformative power in the form of rights, equality, dignity, autonomy, independence, and therefore participation. And this is an area of work where the ILO has been doing quite a bit over the past year. We have published a couple of years back a report, the CARE report, which looks at the care economy as a whole, and I will share the link very shortly. And we are now looking into a new report that will look at care policies and care, in particular care leave policies and their transformative action. And the analysis of all this work on care is very much framed in the international labor standards that provide guidance also on care work, in particular some of the labor standards that look after, for instance, workers with family responsibilities, which is Convention 156. The second point that I wanted to put forward for perhaps further discussion is also relating to working conditions of care workers. And we have seen with COVID-19 how a lot of care workers have been on the spotlight, and clearly their working conditions are often characterized by a void of benefits and protection, low wages or no compensation, and at times also exposure to violence and harassment. In other words, in care jobs are characterized by shortages of decent work. And as mentioned by other colleagues before, a lot of the care work is very feminized, and it's also taken up very often by migrant care workers who find themselves at a disadvantage in the labor market, and therefore they're very susceptible to poor working conditions. If we look at wages, for instance, in some high-income countries, migrant care workers earn over a fifth less than non-migrant care workers, yet they contribute tremendously to societies. And so combined to this, we also need to look at the conditions of a lot of live-in workers, care workers, and the fact that sometimes they're marginalized, they are on precarious and unregulated work, and they're very often isolated. And so it's very hard for them to become part of a union, or of a group or some form of membership-based groups, and therefore to be more protected in a way. And there as well with the ILO, we work through a number of other conventions, in particular Convention 189 on decent work for domestic workers. And the third aspect I wanted to touch upon relates to violence and harassment in the context of care. So persons with disabilities can experience violence and harassment in unique ways and in a greater proportion than those without disabilities. However, their experience remains very often overlooked. But research suggests that persons with disabilities are more likely to experience work-related violence and harassment than persons without disabilities. And so it's very important to make sure that we have legal protections against violence and harassment, including in a context of a care-work relationship. And for this, of particular importance is the new Convention 190 on violence and harassment in the world of work, that also looks after all the different sectors, including the care economy. And to conclude, I think this panel has already given an idea of how complex the care world of work is, being unpaid and paid care work, the many different relationships. And I have highlighted some areas like the transformative care policies and services, decent working conditions for care workers, as well as protection from violence and harassment, as some of the elements that would need to be included in any intervention related to the world of work in the care sector. And all of this, as some other colleagues mentioned, the gender lens is the gender and disability lens are very, very important, in particular when we talk of the care sector. So I will be sharing some links on the chat now, and for us, care work is an area where also we will be focusing more in the coming years, because we do think that it's an extremely important part of an agenda for decent work. And the International Labour Organization has also joined the Global Alliance for Care, which was launched this year actually. And even though historically the care discourse is very linked to gender equality, I think there is certainly much more space and openness now to connect all the dots and to really propose an integrated, inclusive, integrated and responsive approach. And I'll pass the
You'll pass back to me.
I couldn't see you. I wasn't finding you.
That's all right. Thank you very much. I appreciate it. And the complexity that you highlight is something that is central to our conversation here, as well as the advocacy, that work that the ILO does, which is central to all our engagements. Let me welcome Alradi Abdallah, who is like Charlotte McLean-Clapo, is a lawyer by trade and from the University of Khartoum on our continent. So welcome, colleague. Alradi is the beach training officer with the International Disability Alliance and has extensive experience in the work and connecting all those who have trained in this area. Alradi, over to you. You have 5 minutes. Alradi. All right. While we're waiting to check Alradi, who has had maybe some connectivity difficulties, can I ask Charlotte to McLean-Clapo, also the psychologist, lawyer who leads on the disability and is a global disability advisor at the World Bank, to do some of the discussant remarks while we try and connect with Alradi.
Thank you very much, Umesh, and thank you all to all the speakers. This has been really an excellent session already. And as mentioned by Umesh, I was asked to serve as a discussant, and I wanted to start my remarks by sharing a couple of reflections really based on what colleagues have said. And the first thing that strikes me is that the care economy is not a new phenomenon, but rather care work is central to how we live our lives, how we survive, and how we thrive. However, the pandemic has highlighted just how vital care workers are to society, and that people who work in this sector have been neglected for too long. And we've heard that from many of the speakers. But it also should be noted that the care economy is not just confined to families and communities, and that it really encompasses many private and public enterprises that provide healthcare, that provide education and social services. As noted by colleagues, we've seen a shift. We have a shift in global demographics. We have a shift in social and economic and environmental trends. And more recently with the COVID-19 pandemic, we're seeing a lead in an uptick to jobs in the care sector. And this has resulted in increased demand for care workers, who, as mentioned by many others, are often trapped in low quality jobs and often in unpaid labor. A recent report on jobs of tomorrow by the World Economic Forum note that almost 40% of all projected job opportunities in the emerging professions will be created in the care sector between 2020 and 2023. And so this really points to the fact that the demand side of care is high. So for example, in Lebanon, nearly 63.8% of older persons are estimated to have some kind of a non-communicable disease, and most of them will require long-term care. This long-term care is often provided by family members, and again, mainly by women. The reliance of family-based care for persons with disabilities and older persons is common in the developing world. And this has a pressing financial and has economic strains on households that are already in economic distress or in economic shock. Now, in the US, there is also an aging population with a share of those aged 65 and over expected to grow by 21% by 2050, from around 15% in 2015. So it just shows you how these numbers are growing. And of those, about 70% will need some sort of long-term care during their lives. And this is a very live debate right now in the US with the American Rescue Plan, which focuses on infrastructure and includes investments in care work. So in many ways, I think this begins to suggest that there's an urgent need to provide more sustainable long-term care needs for persons with disabilities and for older persons, and support formal care providers and, very importantly, paid care workers. And I would argue that if this is not addressed soon, existing deficits in the quality of care work will create an unsustainable global care issue. And so I think this points to the need for more work to be done to ensure that these jobs, these care jobs, are high skilled and properly compensated. And today we're beginning to have that discussion around what this means for the disability sector. And I want to pose some questions that keep on coming to me in relation to this discussion around the care economy. How do we ensure that there's adequate supply to meet the demand for care that has the potential to create millions of new jobs around the world? But perhaps more importantly for today's discussion is, how do we ensure that disability remains part of those discussions and part of the agenda? So we have to think about how we reimagine care work and care jobs for the future within the context of decent work, as mentioned by Emanuela, recognizing that these jobs are often gendered and racialized and often are invisible. We know that unpaid care represents a crisis because it's economically invisible. But what this means in practice is that somebody who works hard to raise a family, to care for a person with a disability or an older person, is often deemed economically inactive and available for employment, when in fact that person isn't, because that person is caring for somebody else. And so this notion of thinking through unpaid care becomes really important. As mentioned by my colleagues, women and girls, often of color, are performing more than 3/4 of the total amount of unpaid care work, and they make up the disproportionate number of care workers globally. So I think in order for us to advance this agenda, we need to have more robust data, more research, more analysis, more surveys on the cost of the care economy, notwithstanding Leslie's comment around how difficult it is to cost care. We need to look at how we measure care work, both paid and unpaid. So I think what I would like to kind of conclude with are some questions that again remain looming in my mind. We need to be asking questions around who will cover the cost of carers. How do we ensure that care is affordable and that all people are able to access the quality care that they need? What policies do we need to put in place to protect care workers and to ensure that we have regulated systems in place so that we don't have the types of situations that Wonga was talking about in his comments? Conversely, we also need to think about how do we ensure that persons with disabilities, older persons, and others receiving care, that the care itself is safe, of good quality, and very importantly, consistent. How do we pivot to quality care in economies where this work is not even recognized as work, or where the demographic points are really to a youth bulge, and so perhaps policymakers are not thinking about this issue so much? How do we ensure that care for persons with disabilities is part of the care package? How do we ensure that care work is central to the post-pandemic recovery? Because not just because it's the caring thing to do, but because, as we've heard, it makes economic sense. So I have a lot of questions, and I hope that these have helped spark some sense for the discussion, and I would like to hand back over to you, Umesh.
Thank you, Charlotte. It's absolutely unfair because I was hoping that you would answer these questions as well. But I think you set a nice tone for our panelists to think a little bit about this. And it does seem like some of these critical areas that you are raising would be good food for thought for our next webinar. So I'd like to I'd like to just ask Alradi Abdallah, if we can have some conversations with you, Abdallah. Thank you very much. And then just to also tell all the webinar participants that we will have after Alradi, we'll have our colleague from Vic and Mike share their talk. Thank you. Alradi, over to you. Alrighty, we can't hear you.
Good morning, everyone. Good afternoon.
Hi, good morning.
Good evening.
Okay.
I'm happy to be with you here today to discuss this really critical and important topic about the care economy for persons with disabilities. I'm going to share some points that has been raised during our work as International Disability Alliance with our members in regard to the COVID-19 and the response to that crisis. And also some point has been raised by some research and surveys that has been done by our members. Actually, some of the questions have already been asked by Charlotte about the affordability of the care and how to recognize the cost of the care and so on. So I will start with the availability of the care services. In the disability movement, it is really critical for us to receive the care services as a community-based living and to receive care services in where the person with disabilities live, because that is really critical to have universal design of the care services and to contribute to end the institutionalized setting. And this, in regard to this point, in order to ensure the consistency of the care services and it is continualized during the crisis, as we all seen how the COVID-19 and the lockdown has disturbed the care services. We will raise some question how we can guarantee that the care services can be in place during crisis, how we can build a system that is really responsive for crisis. And the crisis settings, it is already like it is already risky settings, and for persons with disability will be even more risk. So in this regard, we will raise the issue of data and how it is important to have disaggregated data. And we already have some data is there. I mean, data system. For example, disability registry system. How we can benefit from disability registry system in order to have that system not only allocated for disability assessment, it also be seen as the opportunity to have more details data that can be used for case management, in where the social workers can use that data during crisis to allocate, to know where persons with disabilities, what the services that they need during crisis, those who receive support, and even, for example, just to link persons with disabilities with nearby care providers. And another point, I would like to talk about the affordability of the care services. And this is really critical point, especially for persons with disabilities. We all know the strong links between disability and poverty, and therefore we need to have affordable care services for persons with disabilities. And this is essential for persons with disabilities to participate and to live independently and to participate and be included in society. And here we can also suggest and discuss more about the role of social protection and how social protection can provide more support for the care sectors in order to provide better services for persons with disabilities. And here we need just to highlight that in regard to social protection, we need to differentiate between schemes that provide basic income security and the schemes that should support the disability related costs, because those are two different functions that the social protection should support. Beside receiving basic income security scheme, persons with disabilities should receive schemes that contribute to the coverage of disability related costs, which include support services and care services. Also, there is a lot of discussion here on if there is a scheme in place, who should receive the benefit of that scheme, persons with disabilities themselves or the care providers, and how that can relate to the power relation. Another point in this regard, also, if we decided that we need to have social protection schemes that can have payment for persons with disabilities, in many countries, not all group persons with disabilities have been recognized as a person before the law. In another language, they don't have legal capacity in order to receive money and to manage that money. We need to end the setting of denial the legal capacity of persons with disabilities. And even the care services can contribute to that, as the care services can be part of the disability, part of the support decision-making system. Finally, I would like to talk about the role of families. You know that persons with disabilities rely more on family members to provide care services, and in this regard, we would like to see family members as a resource and how we can benefit from that resource. But also, we need to see family members as people who impacted by disabilities, and they need many times to stop their work, to stop or to reduce their education in order to cater and to support persons with disabilities. How we can support those families even to guarantee that the support of the family will be there for persons with disabilities, and especially in the during the crisis settings, in which family will be like really close by and can be first responders or even faster responders to support the care of persons with disabilities. Thank you so much. I'm looking forward to receive more discussion in this area. It's really interesting and critical for persons with disabilities to support their participation and full inclusion in society.
Very
Back
powerfully
to you.
said, Alradi, Abdullah. I appreciate that very much. I want to now have a session in which we're going to be having conversations with Vic McKinney and Michael Smith, who we're really absolutely pleased and very lucky to have here. So Dr. Vic McKinney is an academic lecturer, researcher, disability activist, and artist living in Cape Town. He was injured as a fine arts student in 1987. And he has now, he uses and is an activist and strong advocate for the disability in a disability movement here. Vic may want to chat a little bit more. We have 12 minutes there, and then we also want to welcome Michael Smith, and we call Mike here. Mike, welcome. Michael is raised in the District 6 and was removed from there. Has lived through apartheid South Africa and now contributing in a different kind of way. He's joined the Merchant Navy and spent many years at sea working for SAF Marine. And I hope that this also gave it a chance to have all the parliament that you could have, because we can't, it's a resource we don't have at the moment. He's got married, has got 2 children, and returned to work in the printing industry. And he and Vic worked with them, are very closely connected. He enjoys sport, and he is a Liverpool supporter, and so will have my undying admiration forever. And he's also some grown-up children as well as a grandfather. Mike and Vic, thank you very much. The floor is yours. We're really very happy to have you here. Go ahead.
So I'm going to I think I'm going to step in here because I guess I'm going to facilitate this part of the discussion. I'll moderate this part of the discussion. And maybe we start off with Vic. Okay. And I would like to ask Vic, do you mind sharing a little bit more about yourself and the importance of the care economy to you personally?
Thanks, Charlotte, and thanks to everybody. It's really great to be part of this team and this discussion. I think so. Just briefly focus on my lived experience. I was 19 when I had my accident. I was a fine arts student at the University of Cape Town. And then one evening, I was in a road accident. I woke up paralyzed from the shoulders down. Unfortunately, my father was killed in the same accident, and I was an only child. So as discussed before, the burden of care fell onto my mom. And suddenly I was like a baby again. I needed everything done for me. And we relied on friends to help get me up into my wheelchair. We also relied on care attendant schemes from local organizations to help wash and dress me in the morning, and then the person would move on. And that's kind of how we survived for about 2 or 3 years. After about 3 years, we were involved in a court case, and I managed to get a settlement from that to be able to employ my own assistants and have my own transport, which is a big plus. So I became an employer at the age of 22, 23, and I didn't know what I was doing. I hadn't found my voice. I didn't want to live very long at that stage. I didn't thought my life was worth living. I didn't think I could participate much. So it's been for a long time going through that. And of course, I relied on care assistants. And so I did many care assistants over the years. And then was lucky enough to, in 1999, I've had Mike with me. And I have 2 care assistants, and they work in shifts. It's 1 week on, 1 week off. And I've developed a good system over the years, which works well for me. And, moving from that time, which is 30, 25 years ago, I've managed to get my PhD in disability studies at university. I'm married, I have 2 children. And I've traveled overseas and in South Africa. And as Charlotte said earlier, this is central to everything I do. And so it's enabled me to have these opportunities. And I think show what's possible when you have the right support. I must point out that within South Africa, I'm very lucky to have this. I've been privileged, I think, to grow up under the apartheid system. I grew up as a white person, obviously, and then also to have the education I had since then. But also I think most people in South Africa struggle and are dependent on a disability grant, and usually family or friends for their care assistant. So it's trying to find out how can we address that. Yeah. Thanks, Charlotte.
So Vic, thank you very much for sharing with us a very personal part of your life, and I think it really underscores the importance of what we've been talking about and highlights the lived experience. So my next question is to Mike. And Mike, it would be great if you could tell us a little more about yourself and the work that you do with Vic and with others. Over to you, Mike.
Okay, thank you very much. I grew up in District 6. We already moved out of District 6, and from there I went to Kingston. My first job was in the motor trade. Well, I worked quite some time, and then I went to the Merchant Marine Navy, where I worked for many years until I became an engineer. Came back home when my dad passed away, and went to work in a printing works a bit, and the company moved. And then looking for a job, I came to Vic in 1999 and started working for Vic. And basically my work was, I'm basically Vic's arms and legs. I do everything for Victor, basically. I wash him, I dress him in the mornings, I brush his teeth, I help him with his bowel movements, I help him with his catheter, I put him in bed at night, I get him up in the mornings, and everywhere when he travel, I take him. When we travel by air, I go with him, and whenever we travel, I drive him around wherever he wants to go, to varsity and everything. And so as long as I've been with Vicky, which is almost more than 20 years, he's never had a bed sore, which is something great for us. Thank you.
Oh, I mean, that's really impressive that you have a relationship that spans that time means something is working for the two of you, which is very good. So Vic, over the last or this past year, you've been more concerned about your personal care needs and your interactions with personal care attendants. Can you tell us a bit about that?
I think because it's difficult being so dependent and so reliant on others. And so, of course, with the pandemic, you know, it's a deep fear to be at risk through the guys, because we couldn't do normal shifts anymore, especially when lockdown hit. Everything was shut down for 5 weeks, and so Mike just stayed on duty, and Sammy didn't come on duty, you know, for that entire time. And also to reduce the risk of exposure, I had to get the guys tested when they did change shift. So what we do now, Mike will come on for about a month, 3 to 4 weeks, and then Sammy will come on to relieve him. I guess also Sammy's got 2 young daughters and a family. You know, these daughters are still youngsters. They by age about 9 and 11 or 12. At least Mike's kids are grown up. So Sammy's got his family to think about, but it's not ideal because Mike's here a long time and it's tiring. And, you know, we've worked together and we've worked out about time out and how do we sort of make space for that when it's such an intense environment. And then also worrying about, it's expensive to get tests done. So the guys, so for example, if Mike's away for 5 days, 2 days before he comes back, I'll get him tested, and then he must self-isolate at home to check he's clear before he comes back to work. So it's been taxing.
Yeah, no, and I mean, I think thanks for raising the point around the cost of getting tested, because you know that is expensive if you have to if you have to do it, period. But if you have to keep on doing it, it can become, you know, quickly very unaffordable. Mike, what have been some of your main concerns in this past year, given COVID-19, as a person who's providing care?
As a person providing care, it's been difficult to, as Vic said, like I have to be here longer. I don't go home. I don't see my granddaughter so much as I want to. But the need is to be here with Victor, so Victor needs me more. My granddaughter, I can always phone and talk to her and things, but as I say, Victor needs me more. And I can't have Sammy all the time because Sammy's got a young family. He's got a wife and 2 kids, so I have to give Sammy that bit too. And what concerns me most, like, there's not much facilities to train caregivers. I trained on the job. We do not have facilities at train caregivers. And especially, like, what gets me to some parents, they go and the kids are in hospital. When they leave hospital, it's difficult because the mother must teach. There's not somebody to stand with them at the hospital to say, or bring them in to show them, listen here, this is what you do with your kid and how you must work with your kid. It's like with me, like I came and I fell into the deep end. The first time I ever did bowel moving when I was at Vic. First time I ever changed catheter when I was at Vic. I got trained with there's no facilities, and it's basically it's a respect to. I must respect you for what he is, and he must respect me. Because I know he can't do things, so I respect him for that, and he respects me my way, and not like.
So yeah, Mike, thank you very much. And I think you raised a really, really important piece, and that's around how do we ensure that there are facilities in place to train care workers. And maybe if you could both just give me a quick sense of what do you think are the issues that require more attention and research given the care economy, given COVID-19? What are the key things that you think we need to be focusing on?
I think as already pointed to as well, it's that we need disaggregated data. We need more data on disability. I think we need to get and hear the voice of people with disabilities and their care assistants. I think more talks like this, but research on just what is the need, and to help close the disconnect. There's a disconnect between policy and implementation programs. Policy talks about providing personal assistance, etc. But what does it actually mean? What's needed regarding different disabilities, different levels of care, and how do we address it on the ground?
No, thank you both very, very much. We could go. Sorry, Mike, do you want to come in?
Yeah, like what I want to point out to, like some people they can't afford a care assistant, and they have to get their medicines at the hospital and things, and it's difficult because, especially now with COVID, for people with wheelchairs to go all the way to a day hospital get medicine and things. There must be a better situation that somebody can go to them and take in the medicines or meet at a point or something. It's really difficult for people like in rural areas to get to the hospitals, and it's dangerous for them to get them the medicines, the monthly medicines and things.
Yeah, so I mean, I think what we're talking about here is how do we ensure that systems are in place to address the issue around the care needs of persons with disabilities across the board. And again, thank you both very much for sharing with us the lived experience, which sometimes can be a bit, foreign when we're thinking about the policy, when we're thinking about the research, and we, as discussed by many of the other speakers, it's important for us to center this discussion in terms of people and how we make it people-centered. So I'm going to hand over to Umesh now. Thank you both.
Thank you.
Thank you very much, Charlotte, for the very thoughtful facilitation, and especially to Vic and Mike. There's been a really powerful sharing of experience, and also the disjunct between policy and what is happening on the ground, and that the chat is raising that very, very nicely. I think if I have to paraphrase the Rolling Stones, the time is not on our side. And I think perhaps this is a good space for us to bring the panelists and panelists. We are 2 minutes away from ending, and perhaps we could ask if we can stay a few minutes longer, whoever can. But ask the panelists to very quickly share any comments that they want to have. Charlotte raised beautifully thoughtful questions in her discussant section. And if you want to make a comment or something, but briefly, it would be really lovely to have that. And perhaps I can start in the order of our speakers, which is start with Leslie and then have Bonga add something.
Oh, thank you. I don't want to repeat what has already been said, but I'd just like to say thank you for allowing me to be part of this meeting. And I think the challenge for all of us is to see what's in front of our faces, but we hide so well, and to make what is visible to some of us visible to everybody, and to make sure that practices follow this visibility. Thank you.
Thank you very much, Bonga.
Yeah, I also wanted to say thank you so much for including me as part of this, Umesh. I've really enjoyed the panel, and I agree very much with what Leslie said. Actually, is what I wanted to say, that that COVID has really put a spotlight on all the issues around care that is required. So we hopefully going forward, there'll be lot more work being done to try and understand it and see how we can better improve the care of our people that are living with psychosocial disabilities in the community.
And
Thanks, Umesh.
Thank you, Bonga, and to do that collectively. So, Samira, your thoughts?
Hi, yeah, I mean, one thing we didn't talk about is the issue of stigma. And I think this is something that actually drives a lot of people away from approaching the system or the formula. The last thought I want to share is that while we've been advocating as a community for universal health coverage and designing packages, I think there is a golden opportunity for us to actually put that care into those packages because they're affordable, they can be done through the primary healthcare system, and they can actually relieve most of these pressures on the family and on the communities. And then, once again, thank you very much for inviting me to be part of this panel.
Thank you very much, Samira. Emanuela, your thoughts?
Yeah, actually, I found this panel very interesting and also very inspiring stories. I think there is an opportunity now. 5 years ago, the discourse was less prominent, and I think that also connecting the dots of pushing on gender equality, but making sure that we have the disability lens, the intersectionality lens, the economic angle, the social human angle. I mean, I think this is very, very important. And in the context of COVID, there has been quite a lot of pushing towards having better funded programs on care. And certainly it has been clear that if there are no care workers and if people cannot care for their families, societies don't function, and that this has been, and economies don't operate. So I think, I mean, we need to be positive and keep up the energy and really trying to put all these resources, knowledge, information that we have available, and at the same time to disseminate it as much as possible. So thank you very much. It was a great opportunity for me to be with you.
Thank you very much. Alradi?
Thank you so much for the great discussion today. My last remark would be that we need to take this discussion further, especially in the context of low and middle income countries, in which there is no system for care. And if we discuss there, we will indeed need to discuss about the affordability of the service. And above all that, we need to engage further persons with disabilities organization and their family into this discussion as their part of the larger communities that receive care across the globe. Thank you so much.
Thank you very much. Charlotte, some concluding remarks from you before I thank the participants and our team.
No, I mean, I think just to emphasize the point that care is a central part of our lives, and that when we think about care work in the context of disability, we need to think about cross-disability. I think thinking about the comments that Bonga made, so ensuring that we're addressing all types of disability within the care economy is really important. And then I do want to flag the point that while there is a lot of discussion around the care economy, I often feel that the disability piece is not receiving as much focus. And it would be a terrible, terrible situation if that aspect of care ceases to get the traction. And so I just want to make sure that that remains part of the discourse. So thank you all very, very much. This has been an extremely enlightening session. Back over to you, Umesh.
And to pick up that point, perhaps as a concluding remark from our side before we thank all our panelists, is that even when we're talking about the care economy where the disability becomes marginalized and that issue and that point become marginalized, it's really need for everyone to be able to push very strongly, whether we're in the labor movement, in the health, in the mental health movement, in the economy, in the economic movement. our struggles are all interconnected, and so the solidarity and that collective action in the way that people have been talking very powerfully here, especially Vic and Mike, is something that perhaps gives us a part of a roadmap that we want to have in pushing against these subtle oppressions that we have all the time that marginalize issues of importance. I want to just thank our panelists who have been here. Leslie, Bonga, Samira, Emanuela, Alradi, Charlotte, especially for all your leading so strongly in a very quiet way. And I would especially like to ask Anna Hill if she could show us her video so that we can ask our panelists to please, everyone here in the chat, please thank Anna, who put all of this hard work together. Thank you very much, Anna. I really appreciate
Thanks
that.
so much. It's been wonderful to be a part of. Thank you.
Thank you very much. Very beautifully organized. And the final comment, I think, is to just say to all our panelists, as well as everyone in the chat, thank you really very much for participating in this webinar. We do have a plan in mind for another webinar, webinar number 3. It's almost like, this is like Days of Our Lives, where we have episode 1 and 2 and 3 and 4. Without as much drama, I think. So we will have another webinar with the World Bank, with all of our organizations involved here, and look forward to chatting further on this important issue. Colleagues, thank you very much. Appreciate it. Have a good evening. Have a good day. And Assalamu alaikum. And let's aluta continua. Thank you.
Thanks, Umesh. Thank everybody.
Thanks, everyone.
Thank you. Thanks, everybody.